That's it. That's enough on there. Okay. Now, preeclampsia, we're going to spend some time on. Obviously, that's a big deal, huh? There's 3 different ways to look at this, or there's 3 different scenarios that your patient could have. They could have a history of hypertension anyway. That would be called pre-existing and has nothing to do with preeclampsia. So you could have a patient with pre-existing hypertension, has nothing to do with preeclampsia. This patient doesn't have any signs and symptoms. That's important. That patient does not have any signs and symptoms. That patient had a blood pressure greater than 140/90 when you first met him. And it never went down. They've always had this high blood pressure. This patient's at risk for stroke, like anybody else with high blood pressure. They are considered high risk because there is a risk of them getting pre-eclampsia on top of their already existing high blood pressure. So they are high risk, better believe that. They have to have their medications changed. The medications that we use for high blood pressure when you're not pregnant are incompatible with pregnancy. So they get the meds changed really fast. They will always be someone that gets an ultrasound every 3 weeks. And just write these letters down: NST, BPP, contraction stress test, which is a oxytocin challenge test. You write those letters down, we'll talk about them later. They're going to get that every week. This is mandatory. This is PRN. We call this antenatal surveillance. Antenatal surveillance, which means we're just watching you like a hawk, looking for any reason at all to push the envelope. So that's your chronic hypertension patient. They, again, are high risk. They're usually older. They're usually working a lot. They may be already obese or whatever before they even got pregnant. But the key for you guys is that they didn't have any signs and symptoms. They just showed up day one in the prenatal office like that. Very challenging for us to handle that one. Okay, so that's that. Now let's do our preeclampsia craziness. I would use a separate sheet, of course, for this. It's so detailed. When it comes to preeclampsia, it just is better all the way around if you make the triad. So your next page has a lot of room on it. And this is a very good place for you to write some notes if you need to, because they're together. They go together. Both of these things are going to go together. This page and the next one with HELLP syndrome, they're going to go together. Okay? So when it comes to this patient, you have a triad that you must remember. This triad has high blood pressure, proteinuria, hands, face, edema. And you got to be very careful. You've got to remember, edema of the feet are not included. In other words, beloved, nobody cares if the pregnant lady gets cankles. So what? You can't tell her calves from her ankles. That's the way it is. But they are called cankles, and we don't give a shit, okay? You give a shit about her rings not fitting. You care about her face looking puffy. You care about periorbital edema around the eyes. Those are the things you care about. And you also care about protein in the urine because that's crazy as hell. Okay, that's talking kidney involvement, which is a problem. That's insanity. Okay, now, I gave you what you're going to pick up on. That's always called signs. Let me put inside the triangle what she's going to complain about. That's called symptoms. She's going to complain about a headache, which is why it's never normal. She's going to complain about visual changes, that is, if you are smart enough to ask her. She's going to complain about epigastric pain. Of course, she's going to say her stomach hurts, but you're going to ask her where at, and you're going to know that it's generally the right upper quadrant because that's where the liver is. Those are her symptoms. Make sure you know that the epigastric pain radiating to the right side or in the right side of the patient is a late sign. For the blood pressure, be careful. We are, after all, talking young women. So let me tell you what I mean. If you think about it, young women have blood pressures 90 over 50. So I have had to fuss at more than one resident who missed preeclampsia in his patient because I was thinking that 140 over 90 shit, huh? So let's play with 90 over 50. The definition for these women for preeclampsia blood pressure-wise is 30 more than this. Where would that put me? And 15 more than this, where would that put me? If you stuck on stupid and parked on dumb, you're going to let her go home. But she's going to have a seizure at the house because you missed her baseline. Her prenatal records show her baseline. Your blood pressure is checked at every visit. It's going to show your baseline. You cannot assume 140 over 90 is the golden rule. It's 30 beats above systolic, 15 beats above the diastolic, and that's the definition of that elevated blood pressure for this patient. And again, I've had to fuss quite a bit here. First years usually, sometimes second year docs. You're not allowed to miss that in your third year, you're concerning. But your first year docs will miss it. Okay, so make sure you know it's 30 above and 15 above. Now, this patient is the #1 cause of the maternal death. Pre-eclampsia is the #1 cause of maternal death. So the infant mortality is no joke. I mean, the maternal and the infant mortality is no joke. Now, who's at risk? Oh, well, we have the very young and we have the very old. So we have teens. We have AMA. What is AMA? No, advanced maternal age more than what? 35. More than 35. So we have our very young. We have our older mommy. We have smokers, drugs. By the way, smoking and drugs was associated with placenta abruption too, remember? Okay, so you got some of the same doggone things going on there. We have first baby. Just being on your first baby is a risk. We have, I don't know why, So I don't know. In other words, we can't identify a reason. We have twins. We have our diabetic. We got you did it before. So previous history. This is happening after 20 weeks. That's how we know it's not regular high blood pressure. This is happening after 20 weeks. The problem is the patient with pre-eclampsia is having this fancy $4 word. Arterial vasospasms. Her little artery is constricting and dilating and constricting and spasming and doing all kind of crazy shit. And so it's not feeding the kid, that's for sure. It's not really nourishing the baby. So we have decreased blood flow to the uterus, decreased blood flow to the placenta, decreased blood flow to maternal kidneys, decreased blood flow to the brain, decreased blood flow to the liver of the mother, so let's look at each one. We said decreased blood flow to the uterus, which automatically meant decreased blood flow to the placenta. And this baby's in trouble. And sometimes they die right inside of you. So decreased fetal movement would clue us in on that one. Okay, so we know babies are not going to move very well if they're not getting blood flow. That's one. Then we said decreased blood flow, what do we say, maternal kidneys? Okay, that's why you're getting protein. The kidneys are already starting to fail. They're not clearing the protein very well. They're starting to fail. The decreased blood flow to the kidneys gives you the proteinuria. We said decreased blood flow to the brain. This one is huge because it's going to be responsible for why the patient has a seizure. It's why the patient has a headache. Because in response to decreased blood flow to the brain tries to vasodilate and get more blood in it. And now we have a headache. We can have some ICP issues. We for sure have seizure activity that is imminent. And we're worried about that. And the reason why you give a shit about that brain issue is because when you have decreased blood flow to the brain and you have the risk of seizures, the eclampsia part of the word equals seizures. How are you monitoring for this? You're checking DTRs and you're checking clonus. And these both are high. So I want to point out that to you, how that looks. Here's our resident patient. Your patient got preeclampsia. They are at risk for seizures. You admitted them to the labor and delivery unit. You tapped on their patella, right, their knee. Boom. Kicked your ass. Okay? So you say, ooh, shit, that's brisk. Now, that's important for the nurse because you and I, we're going to assume, you and I sitting here now, our reflexes are 2+. This patient, 4+. You and me, normal, we're assuming we're all normal. 4+ is bad, 2+ is normal. So you and I are 2+, your patient just kicked you in the chin, she's 4+. Ordinarily, we would never check for clonus. But since your patient kicked you in the chin, you got to check for clonus. Now, clonus is done with your patient's feet, and you take your hand, cup them around your patient's foot, and you dorsiflex it to her nose, toes to the nose. So you go like this and let go. The patient who is preeclamptic, they're going to take their foot that you dorsiflex and let go, they're going to tap you back. So it's the strangest thing you've ever seen in your life. You did this and they went boom, 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 back to you. The beats that they tapped you with, we count them. And I said, oh, doc, your girl in there, she got 3 beats of clonus. Boom, 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 that's how she did it. So that's crazy as hell. To have any clonus is crazy as hell. And so clonus is a pre-seizure activity as well. So you have brisk reflexes, you got clonus, you got a headache, you got epigastric pain, she's seeing spots in front of her eyes, her hands and her face are swollen, you dipped her urine, you got 2+, 3+, 4+ protein, her blood pressure is rolling out 130s over 80s, in her case that's high as hell. So you got all this hot ass mess going on. Decreased blood flow to the baby, placenta, uterus, placenta. Decreased blood flow to maternal kidneys, decreased blood flow to her brain, and some shit going on with the liver, decreased blood flow. So now you got elevated liver enzymes. We're getting into trouble here. So you got to remember, the pre-eclampsia patient can become the HELP patient. You can't have HELP without having had pre-eclampsia first. Without pre-eclampsia, there's no HELP. Now, you ain't got to wait till you get to HELP. Shit. As long as you got pre-eclampsia, you got a problem. You got a patient that could die any minute here. The only cure for either of these is delivery. The only cure is delivery. Now, we always have mild versus severe. So if you look at mild preeclampsia, which means we don't have clonus, we don't have brisk reflexes, just mild. Think of something mild. It's just mild. We may be able to monitor this patient at home on modified bed rest. It's mild, right? You don't have 3+ protein. You just have a little bit of protein. Nothing crazy. So it's just mild. Now, again, we're doing blood work. We're checking her labs every week. We're doing a 24-hour urine. We're looking at this patient very, very cautiously. And they're getting NSTs and BPPs. You guys know that. Okay. Now, severe preeclampsia, we're going to have to mag sulfate. That is one you got to know a lot about. Magnesium sulfate, let's go ahead and get our little shit on, because this is one of the more important parts of any test, is you understanding what the hell to do with mag sulfate. Magnesium sulfate is an anticonvulsant. It is to save the life of a preeclamptic patient. It is your highest priority, other than the 5 vital signs that you did. When we do magnesium sulfate, we give a bolus. Then we go ahead and use an IV infusion. Both are IV, but the infusion is continuous. And don't forget that this infusion is going to go 48 hours after delivery, 24 to 48 hours after delivery. Some people 24, some people 48. And the patient is high risk, so they stay in labor and delivery even after they had the baby. Magnesium can become toxic Toxic levels, we tell you to check mag levels every 6 hours, and it's toxic at 6 plus. Some people say 8, but I say 6, and we call that the 6-6 rule. Check it every 6 hours. It's toxic at 6. The most important assessment you can do, there are what we call the 3 R's. These are your nursing assessments. You got 3 R's. The most important assessment you can do, reflexes. More important than anything else in the world. If the reflexes are absent, stop the mag. Remember, that's a big deal for your patient because they came in here with brisk reflexes. Now you ain't got none. That's huge. Absent reflexes, stop the mag. The next assessment, respirations. Less than 12, stop the mag. Next one, renal. Less than 30 cc's an hour, stop the mag. The antidote for your patient who's obviously mag toxic, the antidote is calcium gluconate, IV push, ASAP. That's your antidote. You have to teach about MAG. The patient's on strict bed rest. You ain't getting out of bed with MAG on. For the renal function, I just told you, you monitoring every hour. You can't do that without a Foley. You gotta have a Foley. Plus, you ain't going to the bathroom no damn way. You need a Foley. So Foley, continuously, monitoring the urine. You not getting out of bed because your legs are wet noodles. And we teach the patient that if you were to get out of this bed, you will fall flat on your face the way one of our students did, because she didn't believe her nurse, I guess, or maybe her nurse didn't effectively teach. So she said the nurse had left and she was trying to go to the bathroom, and in this case she didn't have a Foley yet because she wasn't severe, and she was on MAG for another reason. She was on it for preterm labor because we use MAG for that too. Anyway, she got out of bed and fell flat on her face with a big old belly. So broke her nose and everything. This patient will fall flat on their face if they get up, and you got to tell them that, because all patients try. They be like telling their boy, she told her boyfriend to put the bed rail down. She fell flat on her face. Okay, so you can't get up and walk. There's no fucking way you can walk on this shit. It's going to make you feel like a wet noodle. And it's going to make you hot. You're going to feel like fire is going through their entire body. It's a very miserable feeling. They may feel sick, like yuck. Okay, it's just the worst experience for the patient. So you tell them, again, hot feeling, warm all over, just don't have any strength, wet noodles, weak, can't do anything. Okay, and you're checking these reflexes, renal, respiratory rate, obviously fetal heart rate and vital signs every hour. This patient, they need a code pink at delivery. We call it the code pink team or NICU at delivery, because we always tell you as a new nurse, when I teach anyway, if you magnetize the mother, you magnetize the kid. So we call it magnetize. You put mag on them. If you magnetize mommy, you magnetize baby. Everything you give to mom goes to baby. The baby might be a little, not too much tone, just kind of like that limp dishcloth like mommy, not too much tone. May not do as well at delivery if you don't have your code here, your team here for the baby. So again, NICU code pink at the delivery. What if your patient's blood pressure decides to do ridiculous things, like a hypertensive crisis? In other words, your patient doing this kind of nonsense. 180s over 110 or 160 over 120. I mean, it just doesn't matter. It's ridiculous. These are ridiculous blood pressures. If they're doing that, you're going to need a drip. Your drips include what I wrote. Hydralazine is one example of a drip. Labetalol is another example of a drip. Nitroprusside is another example of a drip. All these drips. I've done them all. And when we talk about drips, what I want you to remember with a drip is the nurse needs to go up on it every 15 to 20 minutes till that blood pressure comes down. That's what a drip is. The nurse goes up on it every 15 to 20 minutes until the blood pressure comes down. We keep the baby in the room. We don't separate mom and baby unless the baby's too premature to stay. I mean, it's nice, it's ideal, but we have people that don't have anybody in there, and I mean, there's nothing we could do about it, but that's why you don't get any other patients but this one. Maybe one easy DNC or some shit, but you don't get many more people besides this one. This one's pretty bad. And you're doing so much. Every hour you're fucking high maintenance. It's a nurse's nightmare. Okay, so now nifedipine is going to be PO. This is calcium channel blocker. Lasix is obviously a diuretic, and we're going to give it IV push over 2 minutes. You can see this is a very sick patient. Now, normally, we do not give all this crap unless you decide to act a fool. You're acting a fool, we're going to be foolish right with you. Normally, mag sulfate is all they need. Okay? Magnesium sulfate is usually all they need. Now, this patient has seizure precautions, right, y'all? So y'all remember how that goes. Bed low, break on. Remember the little initials I put in your little packet. Bed low, break on, side rails up and padded. Decrease stimuli, no TV, limit visitors. Why has your room got Beechwood Mall attendees in there? Limit the visitors. Not a plaything. You got to limit the visitors. She can always have one or two main people with her, and that's pretty much it. You ain't got the revolving door and baby daddy drama and all this old bullshit. Okay, so there you go.